Yes, thank you.
Oh, okay. Thank you very much. So, good afternoon once again, distinguished colleagues, to invited guests, um, who we very much are privileged to have, to our parents who have been keeping hope alive, and then most importantly, anyone who is an ex-preterm, you guys are the reason why we're here. This afternoon, I want to, on our chairperson, welcome all of us to this session. And as you are aware, this year's theme for the celebration, and today happens actually to be the World Prematurity Day, 17th of November. And our theme for the year is equitable care for every preterm. And it is our hope that no matter where you're born, no matter which facility, um, you should be able to receive the best of care, um, in the context of the resources that is available. Um, I believe today we are gathered here to discuss three very important aspects when it comes to the care for preterms. And I know we have very seasoned facilitators to handle the topic. And I'm hoping that would all take away at least one message that is going to inspire change in our various facilities. So I would once again say a big welcome to us, and do enjoy the rest of the program. Thank you very much.
Thank you very much, Dr. Eugene Mate. Dr. Eugene Mate is a wonderful doctor. He's also a pediatric intensivist at Comfort Anoche Teaching Hospital. Thank you so much, Dr. Eugene. So I am your moderator for this afternoon, and I am Dr. Aduma Odame, Senior Specialist Pediatrician at Hope Exchange Medical Center. Now, the reason why we are here. We have a special guest, and who's also going to be the chairperson for this afternoon's program. Now, many of you may know of this person in his capacity within the media space. You know that he has an Executive Master of Arts in Conflict, Peace, and Security. You know he's a broadcast journalist, he's a public speaker, and he is the creme de la creme when it comes to Masters of Ceremony. We know that he has and currently is the host of Peace FM's morning show. And at some point in time, he was also sworn in as a board member of the National Petroleum Authority. As an MC, he's been hosting a lot of programs. And if you would remember, he used to host the Ghana Music Awards. Now, today we're talking to him in a different capacity, in his capacity as somebody who's related to newborn care and the care of preterm babies. Newborn care, he's well experienced. He has a son and 4 daughters. But when it comes to the care of preterms, this is somebody who has led a program, a project to reduce mortality among preterm babies. What did he do? He has a foundation, and this foundation actually raised funds to purchase incubators for so many hospitals within Ghana. So if we are looking at life stage, the number of preterm babies of talking. And let me allow our chairman in the person of Kwame Sefakai. Mr. Kwame Sefakai, we are privileged to have you. The audience is yours.
Well, good afternoon, and thank you very much for inviting me. I hope you can hear me, though.
Yes, we can. Thank you.
Okay. I'm in a bit of a public space, so I'm not too sure about what the sound quality will be like. But thank you very much for asking me to be part of this conversation. Unfortunately, at a point, I may have to quietly disappear from all of you. But thank you for what you do, and thank you for asking me. At a point, I was wondering, am I the one you're talking about? But I'd like to congratulate all of you for what you do and how far it's impacted our society. And I would quietly relax, sit back, and listen to the deliberations and discussions. And if I have to make an input, I'm sure I will. So I appreciate you asking me to join this conversation, and I'm willing to do it. Thank you very much. Hello.
Thank you. Thank you so much. Making our job easier as pediatricians. That's for a preterm baby and you have no idea what to do, where to put the baby or what. Thank you so much. Mrs. Ipakai, please you may continue.
Yes, I'm listening. What did you ask me, please?
The line was a bit bad, but you can continue now if your connection has been restored.
Okay, so what I was saying is that I appreciate my invitation to join this conversation. And at a point, I may have to leave you, but I would very quietly listen to the deliberations going on. I appreciate all of you and thank you for doing what you do. As you mentioned, we started this project, Coco Charity, several years ago. And we've done the little we can do, but you are the experts, you are the medical professionals. So I'll sit back, relax, and enjoy the conversations that will come through it. If I may have to come in or say anything, I'll gladly do so. But for now, I'll just observe. Thank you very much for asking me to join you.
Thank you so much. So now that our chairperson has given his opening remarks, we will now proceed to have a presentation by one of our sponsors. Thank you. Okay, so now we are going to proceed and have the very interesting, very interactive panel discussion. So we know the theme, which is equitable care for every preterm, and we're going to look at it under a number of sub-themes. One of it is going to address the issue of innovations and solutions for preterm care within low and middle income countries. Another is going to look at family-centered care and psychosocial support. And then the third sub-theme will be financing care for preterm babies. And I know that a lot of us will be interested in that because we are always wondering how we can get finances, we can get funds to buy what we need to buy for our preterm babies and to get them the drugs they need and to help them go on refer minutes and mention the panelists to you, and our panelists will introduce themselves. Dr. Adra, could you kindly introduce yourself to us? Tell us a little about yourself.
Okay, so I'm Dr. Ajopuki Abwachiadom. I work in Confanoche as one of the people that take care of newborns. And I'm a member of PSG, and I'm happy to be here. Thank you very much. And I hope we have a good discussion.
Thank you. Yes, yes, yes. And a lot of questions are coming on to Dr. Prince Odame. Dr. Prince Odame, can you kindly introduce yourself?
Good evening. I'm Dr. Odami, a lecturer biomedical engineering at KNUST. I'm also the lead for child health and innovation at the DIPA lab, and I'm very happy to be here.
Thank you very much, Dr. Prince Odame. So Dr. Prince Odame is my husband. So if you hear me asking him very easy questions, then you know why. All right. Then we also have DDNS Baba Bruce Smith. DDNS, can you introduce yourself?
Hello, my name is Sarah Baba Bruce Smith. Works in Kofanochi Teaching Hospital. I'm a pediatric nurse and works in Mother and Babies Unit. I'm really glad to be part of this program. Thank you.
Thank you so much, Sarah Baba Bruce Smith. And we also have Monica Menu. Monica, can you do us the honors? Monica, can you do us the honors? Can you introduce yourself? Okay, Fam Ann, could you kindly introduce yourself?
Hello, everyone. My name is Anne Boatua Anochimasia. I'm a senior specialist pharmacist and also the pharmacy manager for Child Health Pharmacy at Manochi. I'm glad to be here.
Thank you so much, Fam Ann. And we also have Mr. Christopher Akanbobna, who's the administrator at Holy Family Hospital. And we also have Monica Menu. Monica Menu, let me just circle back to you if you can hear me now. If you can unmute and then introduce yourself.
Hello. Hello.
Yes, hello, we can hear you.
And please, Monica just reached out to me. She's having a little problem with the phone, but she's just sorting it out. So she wants me to introduce her. If that's fine by all of us.
It's fine. Kindly go ahead.
Okay. So my colleague as well, Monica Menu. She also works in Kofanochi, pediatric nurse in Mother Babies Unit. I'm sure she'll sort it out very soon. Thank you.
Okay, thank you. Thank you all so much, my panelists. Now, Dr. Elu, can you set the ball rolling? Equitable neonatal care, what does it even look like in low and middle income countries? What is it all about?
Okay, so when we talk about equitable neonatal care in low and middle income countries, we are looking for, I mean, the ideal is to ensure that all mothers and newborns born in this low middle income countries have received a minimum package of basic care, which will include antenatal skilled birth attendance and then postnatal services, and then address barriers like poverty and then any geographical access that creates inequitable outcomes. So you are looking at things like antenatal, delivery, and postnatal care. So there's a number of antenatal care we want all pregnant women to have. Like in Ghana, we used to be 4 and now we want 8. So we want a minimum of at least 8. And then we know that we want 2 postnatal visits after the baby has been delivered. And then we are shifting as much as possible. We want to shift birth to health facilities. That is the basic. And it's crucial, to mothers, pregnant women especially, to being delivered by skilled birth attendants and then have a little bit of immediate newborn care. So we don't want people to deliver at home or deliver by, what do we call it, traditional birth attendants. And then we are looking for skilled and sufficient workforce. We don't want it to be like it's only when you are in the city that you will have a lot of skilled workers to work on the mother and then on the baby. And then when you are born in a rural somewhere or a very far district, they are not people who are seen to pregnant women and then newly born babies do not have the skills that are needed to help these important people that have come into their life. And then, of course, we are not going to forget about essential equipment supplies. We know that there's a set of essential equipment that are needed for the work that the midwife does, the work that the people that take off neonates do. And these, but not these, and then it's not only these ones, but things like incubators, oxygen sources, resuscitation equipment for both mother and child, vital, and then essential drugs. These are important things that no matter wherever you are born, you should be able to have that so that like the basic thing is being done for you. And then wherever you are born, we cannot forget about prevention of infection. We want that wherever you are born, people should implement robust infection prevention measures in caring for the mother and in caring for the newborn, so that people that are far away, like in the district, in the rural areas, do not have any training, do not have the skills that are needed for infection prevention, do not have the antibiotics that are necessary to combat common infection. And then those in the cities have that. So we are really targeting systemic inequalities, okay? And then we know that the poorest, they are the ones that are really have less resources, and interventions must be on those who are in the poor communities because they are the most vulnerable population. And then they are also in the most impoverished. And these essential gaps need to be closed so that we can have a facility or a hospital that is in readiness to focus on ensuring that when a pregnant woman comes and starts her pregnancy journey, it is safe. And when the baby is born and needs any essential management, it's safe and it's standard. And then we strengthen the big facilities and the community care so that referrals are also seamless, so that there will be easier continuity of care with an overall, I know this is preterm, but you know that the care of the mother and the child is like, and the newborn is like a continuum. It's not like different things. So we have a mother we care before she gets pregnant. We have a mother we care when she's pregnant and when she delivers. And then when the baby comes, we care for both the mother and then the baby. And we want it to be as seamless as possible. And the most vulnerable communities, the most impoverished communities, should not have less of the standard of care compared to maybe urban areas or richer areas in the country, especially in low and middle income communities. So that is what we are looking at. We are making sure that the standard of care for caring for all our vulnerable mothers to our vulnerable newborns, especially our preterms, is maintained across every part of Ghana, every part of any corner, so that wherever you are born, that same standard of care will be given to you, irrespective of whether it is a poor area or a rich area. Thank you very much.
But Dr. Let's be realistic here. Obviously, the baby who is born in Inframa near the Afram Plains will not have the same care that the baby born in East Lagos will get. So how are we going to close this gap? Because when we're even looking at neonatologists, how many are you in the country? There are even regions without pediatricians. So realistically, how can Ghana ever close this gap?
Yes, as you said, I mean, this is we always have to look at the ideal, and then we see how we can at least, if we aim for 100%, if we fail, we can fall back. Somebody say we can fall back to like 60%. And then we know that these are the gaps, okay? And you ask realistically, how many people are neonatologists? I can tell you that we are not a lot. If I'm bold, I'll say that we are not even up to 10. I mean, I can only count up to about 6 neonatologists that I know. But then I can say that since I was in training to become a pediatrician, remember, I'm a general pediatrician first before I subspecialized to neonatology. The number of pediatricians have escalated from the time that I had my training. And we have more pediatricians in regional hospitals and even some teaching hospitals have more pediatric residents, but it's not enough. I mean, I cannot say that it is enough. So what are we going to do? We must recognize the gaps and then see how best we are going to fill it. So what are we going to do now? You know that, what are the gaps? The first gap, you see that we don't have the readily, you cannot say that you want every neonatologist in every crook and cranny of this of this country. We know that even in well-developed country, there's I mean the corner hospital does not necessarily have a neonatologist per se. They are usually found in maybe secondary and then tertiary and then quaternary hospitals. Okay, but then what can we do? Who are the people who are on the front line helping these women? They are community health midwives, and they are midwives and are registered nurses that are helping them. So what can we do about it? Can we train them? Can we facilitate train them in the standard of care for our mothers, so that some of the things that can be put in place, that we reduce the incidence of or the prevalence of preterm birth, can be picked up in the mothers and can be managed so that we reduce the incidence of preterm birth. That's one of the things. The second thing is, apart from training, what can we let other people, our pediatricians in district hospitals, in regional hospitals, in teaching hospital, mentor these midwives, have a way of calling them, a way obstetricians talk to midwife, show them what to do, and then even if they want to refer, what to do before you can refer. Third thing, basic equipment, okay? Basic equipment that they can use. I mean, if you are at Inframa, as I heard it, I'm not very sure I got the name right. Forgive me if I got it wrong. And then you know that you are a midwife and you deal with pregnant women who come in labor. How is it that that midwife hasn't got a resuscitation bag? She hasn't got an ambu bag that if a baby needs some resuscitation, she will get it. She doesn't have different sizes of mask. How is that possible? And then she has no essential medications like antibiotic. I mean, that she can give to her mother than herself. And then, of course, also if the baby, she suspects that the baby might have infection, she can give to the baby. I mean, these are things that are gaps in the system that we may have to look at and then help bridge those gaps in order to save the number of babies that we are losing in Ghana from neonatal deaths, and especially our preterm babies, who are the most vulnerable of all the newborns that are born. Thank you very much, Dr. Dan.
Thank you. Thank you so much, Dr. Ajoapukia Pwache Iadom. Esquire, please, if you're on the call, could you kindly introduce yourself? I don't want to make any wrong introductions and get sued for it. Okay, now let's move on with our questions and let's come to Dr. Prince Odame. So Dr. Prince Odame, you are a biomedical engineer and you do a lot when it comes to developing devices and coming up with AI tools that healthcare workers can use. What are some of the problems that you have seen or envisage when it comes to developing devices for us to use in health for our tiny babies?
Thank you very much. The first problem I'll talk about is we as a lab, as an institution, we realized that we've been involved in a lot of research over the years. We sit in the labs, we come up with problems we think you guys have, we come up with solutions for them, and then at the end of the day, the solutions, they don't get adopted. That is, they are not accepted in your facilities to be used. So we decided that to solve this, we will have to undertake stakeholder engagement with you guys to hear from you what actually the problems you have are, and then come up with solutions that you guys can adopt. And ever since we started that, we started seeing improvement in the reception of the innovations that we've come up with lately. Some of them being incubators, and then also phototherapy devices. And we've also worked on exchange transfusion devices also, and then sleep apnea devices as well. So that is one of the challenges that we had. And then overcoming them, we decided to come to you guys, and then you guys tell us exactly what you have. Now, the second challenge I'll talk about is financing this innovation. How do we finance them to prototype? And then after prototyping, how do we get them tested? Animal testing, clinical testing, how do we get approval? And after all that upscaling of these devices, it requires a lot of money. Money has been a big problem for us. How do we get the money to prototype, to test? And then after it's accepted, how do we also upscale so that it reaches all the corners of the country that we want them to reach? That one solution, we don't have a good solution now. We try to write for grants, and if you are successful, that helps to an extent. But then oftentimes, as soon as you exhaust the funds for the grant, that means that the work also comes to an end, or it comes to a standstill. And the other problem I'll talk about is bureaucracy that we also face when it comes to certain information we need, especially data that we need from the hospitals. We decided to use our AI tools that we have to come up with a solution that will allow the medical doctor, just by using their cell phones, to take a picture of the baby that has been rushed, or the preterm baby that has been rushed to their unit, so that they wouldn't have to take the time to take their weight and also to check their height. If they take a picture with their cell phone of the baby, the neonate, they'll be able to tell the weight of the baby. They'll be able to tell the height of the baby, and then use that for treatment and then drug determination, basically. But then one challenge we faced when we went to the units is that where are the letters that you need to come up with so that we to our facility. Oh, Adma, can you hear me?
Yes, I think we lost you for a second, but we can hear you now.
Yes, I said I came with some students to Kintampo. We first went to Tachiban so that I exposed them to the hospital setting, what clinical engineers do, and then we proceeded to Kintampo. They are now at the force. I had to go on a canopy walk with them to ensure that everybody is safe. I just finished, so I'm a bit out of breath. So I'm asking if you
I hope you are safe
come back in a few
yourself.
minutes. Now, is that okay?
Sorry, could you say that again?
I said, is that okay? Could you come back in a few for me to catch my breath? I just finished the canopy walk with them.
Oh, okay. So you need resuscitation. All right. So let me circle round and then I'll come back to you. Let me circle to Baba and then I'll come back to you. All right. So Baba, we've talked a bit about what equitable neonatal care looks like, and we've talked about some of the challenges in rural Ghana and in urban, in rural Ghana, and the gaps between rural and urban Ghana. Now let's come to the capacity of our neonatal nurses and our midwives. How can countries like Ghana strengthen capacity? Because we have workforce shortages, and you know that now with the current brain drain to the UK, to the US, and Canada, I hear is now a wonderland for our nurses. So what can we do as LMICs to strengthen this?
Thank you. Okay, just like you just said, when it comes to the capacity building and the shortage in the workplace, it depends on how it is like. Let's say it's a short-term shortage in the capacity of workforce or a long-term. For example, let's say in the ward, we have a shortage of nurses just for a short term. So let's say somebody gets sick, there is an emergency here and there. And so the number of staff to take care of the babies are not enough. What we normally do is it's all about being each other's keeper. So if we need to restructure ourselves, we do it quickly. Call those who are on days off to come in help, or if somebody is on leave, we can call the person back to help. Again, if it's a long-term shortage we are talking about, example, brain drain as you are talking about, some people have to go for greener pastures, some have to go to school, some have to also vacate their posts. this one becomes a little bit of a challenge. So normally when you see that this is happening, we normally have to engage our management team. Let them know that as, let's say, when we started the year, we had an X number of nurses, midwives, let's say 20, 30. As we're going down the end of the year, the number keeps on reducing. So what can we do to help? So that we sit on the table, management sits on the table, see around if government is not recruiting at that time. It's possible some directorates, some places have more number of nurses. So we can recruit some from such places to the places where the numbers are reducing very drastically. So if this happens too, then we need to train. We have some that are neonatal specialists. We have some that have gone through the training, helping babies breathe here and there. So if we get these new nurses from the different director, the different places to come and support the shortage, we start with our training, train them on what we do and how to go about it. So those who already have the training would also become a mentor to these new nurses, okay? If for just a short term or they are coming to help for a longer term, so that together we can help bridge the gap. Again, the training, as I'm talking about, when people come into, we should always know how to appreciate people, okay? So that in case there are shortage, you can always call people in to come and help. So we can train them, find out our problems. When it comes to the training needs, we have to do a needs assessment, see what we need as a unit or as a facility. The facility to also differ from places to places, like the urbans, like the tertiary. What we need might be different from what people from the urban need. Do an audit on our mortality and morbidity. Then we can draw a training program so that we know these are the training we need to have to help curtail these problems. Talking about that, we should also have a refresher courses here and there. You know, as time goes on, you get new nurses, just like I said, or there's evidence-based program, evidence-based research that has come. With these refresher courses help us to be able to be abreast with time. And also when we do this, we should also try and do follow-ups. Okay, so we have trained our nurses on helping babies breathe. So what next? We should follow up with our new nurses, or our mentors should follow up with those who have been trained with this program to see, are we practicing it the way it should be practiced? And then we also think about our referral systems. Okay, there was a time we did a program, I think it was P4R. We sat down and we are in the tertiary institution. So we sat down and we were looking at those who bring referrals to MBU. So we could gather the gaps. So some of us were asked to go around, find out their assess their MBUs, their neonatal units. Let me call it neonatal because some places not only MBU per se. The things that they work with, the things that they need. Okay, then we get back, sit down with the appropriate quarters to think about the training program to be organized. Okay, example like the helping babies breathe, so that we know the things that can be done to bridge the gap. Also, we are at times we are there, and a district or some place will call some of our colleagues. We have we are doing a KC we are a little bit confused with that. Can you throw more lights? So you can also do the phone call thing. There's phones here, there is video, there's WhatsApp. So that where we can have a WhatsApp group where to meet other colleagues in the urban places. So when they need help from us, we can also stretch our ideas to them. Thank you.
Thank you, Baba. So let me ask you one question. So we know that we don't have many neonatal nurses. We don't have enough, right? But then with certain training institutions, right, they'll say that you need to do a number of years, you need to have a certain belt color before you can come back to the institution or come for training to be a neonatal nurse. How does this really help us? Can we not say as a country that because there's a shortage in that area, let's waive the rules, let's tweak the rules a bit so we're able to get more people? Please, what are your thoughts?
Thank you. I agree with you perfectly. Like I always say, new nurses come around. You see, you can pick some people, some really have the love for what they do. Some people come to a unit, a midwife might want to go to the midwifery aspect. Some too come, you can see that the love for the baby is that bad. The person can just be a nurse, staff midwife. So we can pick up these ones, change our institution, just like you're saying, so that we can build the capacity, train them, come back. They also go ahead, train more people, so that this shortage and capacity will be a thing of the past. So I agree with you. The institution should set back. The management should kind of change a little bit of our rules. When need be, we can always not bending the rules, but modifying it to fit the purpose of it. Thank you.
And then I know I asked everybody too, but I'm asking you three, forgive. But for instance, like this Pediatric Society conference that we are about to have, we are having certain people complaining about the cost, etc. But then you need this CPD knowledge to be able to improve the quality of care, your skills that you render to clients. So how could we go about it? How can we ensure that CPDs are delivered sustainably in a low resource setting or in settings with pockets of resistance?
Okay, thank you. So again, cost is a problem. As we are talking now, our new nurses, most of them, should I say all, most of them have not been paid. Some really love to come for such conferences, but honestly, the money they don't have. So I would think management can help out with this one. We can pick up some people, pay for them, or if not paying, or you can pay some amount so they can add up. Or can also talk to some institutions, some donors. So we have people who come to donate here and there. And because they have the love for the babies, when they come to our unit and they talk to us, they ask us our needs. This can also be channeled to them. So there is a program like this, and that goes into it. So we're hoping if any little amount or anyhow you can help will go a long way to help a baby in the future. It can be a form of donation of money. So these money, some can be channeled to our new nurses to pay for this cost and attend the program. So the management team and other bodies should come around and help those who are really in dire need of money and cannot afford to come. We can come in and support them so they can come for the program. They'll come back and train others who are not able to come. Thank you. Thank you.
Thank you. Thank you so much. And I realize our sixth panelist is on. Esquire, Christopher, could you kindly introduce yourself before I continue the questions?
Thank you very much, Dr. Duma, and thank you everyone for the opportunity to be here. Christopher Akambobnap is my name. I serve at Holy Family Hospital. Call me a servant. I like to think that in my role, we have facilitated an enabling environment for quality healthcare delivery for newborns in our hospital. I'm happy to be part of this discussion. Thank you.
Thank you, thank you, thank you so much. You have no idea how excited I am that you are on, because I'm going to bring all the financial questions. I'm going to bring all of them to you. So please get ready. So let me allow you to breathe a little whilst I come to Monica. Monica, let's move from the health worker and let's come to the family. What role do you think the family and community can play in improving outcomes? We know our culture, we know our traditions. What really can the family do? Okay. Whilst I'm waiting for Monica, let me just circle to Farm Anne. Farm Anne, could you let us know how countries like ours can use local data decisions? You know, we do generate a lot of data. Many of us don't look at the data, but how could we use it to guide our clinical improvements in the clinics, in the newborn units?
Thank you very much. So I'll refer to what we did some few years ago, because you are asking a data question. What the team did at MBU at CAT was we realized that for some reason, our gastroschisis patients were not doing well for years. We're not getting patients surviving. You only be able to do this if you are tracking the data and seeing what you are doing in terms of care you are providing for them. And it is this diligence that led to us trying to find solutions and finding out the whys. And in so doing, it opened up something that turned out to be very beautiful, and it has changed the practice at MBU. It brought together both the doctors, the nurses, the pharmacy team to try and help these babies survive. We're looking at the whys. And what actually broke the case was actually a nurse who was able to identify that the source of infection that we were all suspecting was killing these babies was from a possible contamination of the parenteral nutrition that was being prepared at the ward. It's just an observation. The nurse alerted me. I also came around to observe the practice, and I kind of agreed with her. But then after agreeing, what next can you do? Because we could not still continue to do it there, but there was no place to also do it separately from the ward. But I've always loved teamwork and what the team was able to do. And then we went around looking, and I think when you look hard, sometimes we get a bit frustrated with a lack of things, but some way, somehow, there are things if you really begin to look hard enough. I don't know whether it was just a bit of luck or diligence. I was just walking about and I just chanced on a machine. I just looked at it closely and I realized that, oh, it's a laminar airflow bench. And I was like, oh, who owns this? It seemed abandoned. So I tracked and followed it. I realized that it was a donation that was based, but it was rejected because it was not the biological safety. I said, oh, we want it because we need a sterile place to prepare the medications for our babies. And they said, oh, if you want it, you can keep it. Now, where do you even keep such a big machine? But then the team on the ground, the nurse managers, and everybody, we managed to find a place. So because of that, we were able to solve our issues, reduce infection, and we got the baby surviving. So to come back to your question, it's always very important to look at your data and find out why things are not working. And if you begin to look at it hard enough, sometimes it may not even be wild things. It might just be simple tweaking, changing of practice, or doing something differently, or collaborating more. That could just be the difference between saving one baby and losing a baby. Thank you.
That's interesting, right? You were just walking around and then you saw something and realized that, we can use this in saving lives. That's very interesting because it brings to mind local innovations, right? How can we adapt these to our context without compromising on quality? You know, when it comes to the older pediatrics, they couldn't get dialysis. So then they make a concoction. Harina, forgive me, they make some concoction. Hey, HOD, Anima, please, I hope you're not on the call. Of Ringer's lactate, this and that, and then they use it. How can we use local innovations, but still make sure that we maintain the quality?
Dr. Adama, you're breaking up a bit, but can you come again?
Hello. Anne, sorry, I realized you wanted me to repeat. When it comes to older peds, Haruna and his team, they couldn't get dialysate, so they'll make a concoction with your ringer's lactates and all those things, and it would serve the same purpose. So I was asking how are we able to make sure that our innovations still maintain the quality? Because you found a machine and you thought that I can use this to serve the same purpose. How are we able to make sure that innovations can still?
Okay. Hello, can you hear me? If you can, I think that these concussions, you can start from the concussion, because sometimes if you don't have anything, that's all you have. But as Dr. Eno was saying, we already know the standard. And sometimes it's just a matter of pushing for those facilities. It may take a while, but I think sometimes we get stuck with the concoctions and we don't push anymore because we think that, oh, you're not even going to get, and we're getting some results. But it is the ideal, because in these environments that you are doing these concoction, you may be saving some babies, but you are also risking infections in these and these machines, though initially the cost may be huge, but if you are looking at it in terms of infection prevention and even cost saving in terms of medication and ability to share the medications among patients, it's eventually very cost effective. And sometimes there are even donations that other people are willing to donate. But if you don't put those things on the tables of management, when they go to those decision bodies or they are approached by a donor, they may not even realize that this machine is a need for them to even bring it up. So yes, if you don't have anything, you try to minimize the risk of infection to the best of your ability. But let's not just stay there. The concussion, we know the right one. Now I'm very glad that the renal unit, now they managed to push, and they have their PD fluid nicely formulated by a pharmaceutical company in Ghana. So that is what I'm trying to get at, that you can start wherever you are, but let's not end there. Let's push for the ultimate that reduces the risk of infections whilst we are also trying to save the patients. Thank you.
Thank you very much, Fam. And I think that's a great point, because when it comes to warmers, when it comes to phototherapy for our newborns, our preterms, we used to make these wooden structures, put light bulbs here and there and use it. It may suffice for a day or two, but we should push to get the standard. We should push to get the right thing done for our babies, For our preterm babies, nothing less than the standard is good enough for them. So thank you so much for that. And Haruna, I'll buy you drink, okay? So forgive me. Your concoction, even though I'm calling it a concoction, I think it also was accepted as something that could be used, and it did save lives. And the great point is you didn't stop there, but you pushed on to get the right thing. So now that we are still talking about innovations, let me come back to Dr. Prince Odame. And let me just ask now, you were mentioning that sometimes you have some challenges when it comes to the ethics, when it comes to what the clinicians demand when you want to work with them. You were talking about an AI tool for neonatal, no, not for neonatal jaundice, but for weight and height estimation. Could you kindly round up on that?
Oh, okay, thank you very much. So, we know AI, you need data. The more data you have and the good quality data you train it with, the better the output. So with that project, what we wanted to do is to cut down the time of the doctors having to prep the baby to determine the weight, check the weight, and get the height before they can use it for diagnosis and for treatment and for drug administration. So what we did is, if we take a lot of pictures of babies, neonates, children, and then we train the model, then we can host a model on the cell phones of the doctors. And so when the babies come in, they can just take pictures right away, and then they have a good estimate of the weight and then the height, and they can use it for whatever they need to use it for. But then the challenge is getting this data. We need to go to the hospitals. We thought about going to the schools. You go to some of the schools, the parents are not willing to agree for you to just take the weight and then the height of their babies. So we faced that challenge. We had a few of the schools, grant us the permission to do that. You go to the hospitals to the problem is the nurses are busy at the OPD. What we needed them to do, we've built a tool that if they use, once they take this data and they are recording, they just also enter it. And we sitting in the lab, the values will reflect. We can use it that we face. Go to the hospitals. It's a huge challenge. Sometimes you go and write a letter, it takes months before you even hear from them. We tried a lot with Confanoche sometime in some years ago. Because of the hurdles, we've stopped. I've given up on trying to get anything done at Confanoche right now. So we are looking at some CHAC facilities now. And luckily for me, today, as I mentioned, I brought some of the students that intern with me when the semester ended. They've been with me for over 2 months now. And I brought them to Holy Family today, Techiman. And I met this gentleman. I was with the engineer there, Abdullah, and I was looking at some of the equipments that were outdated or broken that had been dumped. I was by the dump site, and this gentleman walked up, this doctor, and he stopped, and we started talking because I was just saying some of the things I'm seeing that have been thrown away. We could face them. We could use some part of them for the work that we are doing. But then there are challenges. Even I asked the engineer, this part, can I take it back to the lab? We can take a look at it, reverse engineer it. There was a firefly that was broken. They were trying to fix. Then he said, no, I want to give it to you, but then we have to write this, you have to do this, So that is a huge challenge. If you guys can help us, then we can shorten the time that it takes for us to get some of these innovations in a hospital for you guys to use. If you guys will help us and then grant us access when we come to your facilities looking for this asset. So the gentleman said that he has a private hospital And that I discussed this challenge with him. So he says I should try. They have an association. I never knew. Private Health Facility Association of Ghana. I've never heard of them. He just told me that he thinks that is something I should try next time, because now they are even looking for hospital beds, because there's a new thing out there that if they don't have a certain number of beds, then they'll be downgraded to clinics. So a lot of them are looking for beds. If we can help them do that. So I will plead with you guys that as we've started coming to you to listen to the problems you have, so that we can tailor solutions for. You also make it easy, on us when we come. Shorten the time, the hurdles that needs to be, overcome to attain some of these clearances. If you can shorten them for us, it will really, really help us, so that we can get these solutions to these rural settings that they don't have most of these equipment. They can deliver quality healthcare to these preterms and these babies. Thank you very much.
Okay, so thank you for that. And it's good to know that we are widening the net. Now involving the private facilities association as well. But let me come to this equipment for children, for the parents' desires, the parents' abilities into the whole process.
Hello, Dr. Aduma. I think the line was breaking up, but I just said about parents' involvement or something. Could you clarify? I couldn't
Yes,
hear.
I was asking,
I don't know. Mhm.
when we are designing tools and devices for children, for newborn,
When we are designing them,
desires and their abilities in the innovation process.
I don't know whether it's a reception at my end or I couldn't hear, but I'm hearing parents and innovation, and let me go ahead and maybe you could clarify for me. We have um, a thermometer for parents to use at home to check the temperature of babies, and we thought about uh, parents who might not be literate, who might not be able to read the temperature reading on the thermometer and interpret as to what needs to be done. So what we did was that we've programmed it in such a way that when they take the temperature of the baby at home, depending on the temperature range that they get, it will light up red, yellow, or green. And green means that the baby's okay, nothing needs to be done. Yellow meaning that okay, the borderline of catching a fever. So maybe you should start doing something like wiping with a wet towel or something. Red meaning that the baby has a fever. You should take the baby to a health facility to receive care. And also, in addition to the color coding, we also added audio or voice feedback. So, most of the languages, about 14 languages, local languages in Ghana. So, after the temperature is red and the color is lighted, there will be an audio feedback. Akwaraa no ho ayɛ hye, Trumika nafa no kɔ hospital. Akwaraa no ho ɛyɛ hye, nti fa towel bɔ nsuom na fa pepa no ho. Feedback like that. To help the parents who might not be able to interpret the readings on the thermometer know what to do and know when to seek care for their children.
Okay, thank you very much for that. So the ability of the parents, the literacy level of the parents has been factored into the thermometer that is being designed for our children. That's great.
Yes.
Monica, are you on the call? I am trying to find you, but I'm unable to find you. Monica, please, are you on the call so that I ask you one or two questions? Monica. And as I wait for Monica, let me just read out one or two things that came up in the chat. That's why there's the need for training for birth attendants on helping babies breathe and referring to a hospital that provides care for preterm babies. She was saying that in response to Dr. Enu's submission, and that access to transportation should be included in the care and plan of caring for preterm babies who are in facilities that do not provide care. That's great. Now, let's talk about money matters. And let me come to Esquire Christopher. Esquire Christopher, you are warmly welcome to this evening's discussion. Now, what funding or innovative funding mechanisms, financing mechanisms, can help us care for our babies, our preterm babies in low and middle income countries? What funding or financing mechanisms can help us? Esquire.
So thank you very much, Dr. Aduma, and thank you to co-panelists for all the intelligent contributions made so far, and I associate with many of the comments shared. And you will find in their comments the sustainable funding mechanisms. So first of all, I like to say that I admire pediatricians a lot, especially with your advocacy skills. So talking about funding, it starts with planning. And I am very happy to have also on call some of my very strong, dependable team members. Dr. Jacqueline is on call, Dr. Echo is on call, and they will readily relate to what I'm talking about when it comes to planning and how we have done it in the hospital. So what do I mean? In the previous contribution by Dr. Let me see, I noted her name. The first speaker, let me say, I think is Dr. Pokua, and then Pham An. They refer to very low-hanging fruits, what we can do to save some costs, infection prevention, and the kind of things that we can do. We must sit at the table with one mindset: transparency of intent, transparency of deliverables must be right from the beginning of the year. So where we have pediatricians and where we do not even have pediatricians, but we have medical officers taking care of babies, there must be a deliberate act on the part of the clinicians leading service delivery in the child health to bring to the fore the needs of the department, that this is appropriately planned for from the beginning. This is the key thing. We don't start the year, roll into the year around June, July, before we suddenly realize that there's a need for a firefly just because we were at a conference and there was an exhibitor who showed us how beautiful a firefly is and what it can do. We also have, for example, had an intention of what we want to achieve when it comes to child health service. In this case, because we're talking about prematurity month, what is our deliverable as far as premature babies are concerned, and what is needed to ensure this deliverable? So planning is very important, and with your strong and adept skills in advocacy, this shouldn't be a challenge at all to get the attention of management at all levels of the healthcare delivery system, from primary, secondary, tertiary. And I think this is my first preliminary remark. The second thing I would like to share with is you look at funding from two sides. You like to, anytime we talk about funding, look at it from directly the revenue side as to how the money is coming. But I like to urge all of us to also look at how we are also able to save costs, because when we run a hospital, it's across board. Even though child health care will be seen as child health, OBGY will be seen as OBGY, and so forth and so on. But we have to look at the fact that all the service areas are not necessarily bringing the same revenue streams, and we need to support each other through cross-subsidization. We make some little income there and use to also finance some other activities. In this regard, the prevention of some of the conditions related to premature babies is one thing that we look at in terms of saving costs. In Dr. Pokua's presentation, she shared the burden of caring for premature babies. It requires high skilled staff, requires high sophisticated equipment, a very sterile or semi-sterile environment, and so forth and so on, and even advanced medications, antibiotics. Antibiotics used in NICUs are one of the highest across our institutions, wherever you find them. So the question is, wouldn't it be a low-hanging fruit to look at the prevention side? And that comes to some little investment in public health, that public health is able to bridge the gap between institutional care and community information and awareness of the things that our mothers can do to prevent our babies from getting to NICU, that would then put a burden on all the things that Dr. Pokua shared earlier. I know for us as institutional managers, we are often looking at where the money comes from. And so you might think, okay, public health is not going to bring us money. Why would we have to finance the transport for them to go out every day to do the community-based outreach services? But it's necessary because then it takes the other side of the funding we are talking about, which is saving us the costs and the burden that is associated with taking care of what? Newborn cases. If we were to look at specific examples of what we can do by way of funding mechanisms, I think we should continue to re-emphasize the role of mandatory National Health Insurance Scheme subscription for all our community members. Is the lowest hanging fruit. This social financing mechanism system just has very little contribution from the subscribers themselves, whether from the formal sector or the informal sector. And it's a list that any member of the population can do. So when we do our advocacy, this is one thing that we should endeavor to promote, even though we may not be agents or active workers of the National Health Insurance Scheme, because we are concerned about mothers arriving in our hospitals being uninsured, and therefore their newborn babies are not also covered, and they bring a burden that we must then respond to. This can be lightened if they were covered with insurance. And one of the things we do in our hospital, if we were to give an example, is to identify all these and even help to register them on health insurance if they're truly so poor. Because it's cheaper for us to register a pregnant woman on NHIA who does not have any form of insurance and surely will not have money to come and make out-of-pocket payment. So in the time of need, whether it's during delivery, admission to NICU, or cesarean section, at least there's some minimum financial protection for that person. And we also then get to claim from NHIA. So let's look out for all our antenatal clients, because that is where the whole story starts as far as funding is concerned. If you ignore them, they'll come back as liability. Nobody will see a pregnant woman dying and will not save. You will do it, and then the cost, you can do whatever you want to do with all the detention, but eventually detention is illegal anyway. But they will go home, and when they go home, the cost that is there, institutions cannot get reimbursement from. So mandatory NHIS subscription for all our clients, starting from A and C, and that is what ensures that when they bring their babies out, we're able to care for them, whether it's in NICU or anything. One other system one can look out, because again, NHIS still has its own limitations, as much as it does solve a lot of the challenges from primary to secondary level, and even some bits at the tertiary level. We still have limitations with it. And so we can be innovative about how to finance certain critical equipment. One of the things that Dr. Pokuya mentioned in terms of the sophisticated equipment required. I remember when the first time we had to invest in a Firefly, and I'm glad Dr. Jacqueline and Dr. Eko are on the call. We realized that we needed to sustain the equipment, to buy more in order to increase access, but even from the beginning, how to raise the funding for what we are buying. So we generally engage our municipal NHIS team that we're going to buy this that can improve quality care for our newborns. But we will do what we like to call a demand pooling system, a micro contribution by all mothers who put their babies on this Firefly. It's micro, it's not that much, but even if it's 5 cedis per baby for each admission, it brings in something little. From this, I remember from time to time, and this was a dedicated account. So Dr. Jacqueline will prompt us that we have raised something, let's go for the next Firefly. And this is how we're able to go far in terms of, this is not enough, but at least it's not zero. It gives us something, it makes the community feel involved in helping to improve their own quality of child health services. And in the end, the municipal health insurance team also were conscious of 1 or 2 of such contributions in the NICU, to the extent that this was tied to some deliverables that everybody could appreciate. We would always have the poor among us. That's what the good Bible says. And so even in the midst of all of this, you will still have some people that will skip NHIS. You will still have some people who cannot pay the 5 cedis contribution to ensure replenishment of equipment or whatever. And so we'll still have some people there that we have to take care of, let's say for gratis. So in our hospital, we have a little fund that we call the Poor and Sick Fund. And I'm safe to say that the pediatric department takes a significant part of this Poor and Sick Fund. This Poor and Sick Fund largely relies on private individual donations, contributions, whether from staff, well-wishers, sometimes partners visit, or when we even have an annual celebration of World Day of the Sick, collections or special contributions are made, and this is put into this small fund for support of babies that are admitted in NICU who are in need of one medication or the other and are not able to care for. As for ambulance referral in instances like that, we basically have to provide it, and we cannot put that task on the Poor and Sick Fund. But in our own small way, these have been the little innovative solutions we have adopted over the years, worked around, perfected a few of them that have served us well. And I'm sure they can be made better. And I want to pause here for more contributions. Thank you.
Thank you. Thank you so much, Esquire. I'm going to come back to you to ask you about health insurance and these top-ups or these 55 cities, what they say about it, and BNI, etc. But before that, our guest of honor may need to step out. So I just wanted to come back to him. Kwame Sefakai, is there any intervention or any comments that you would like to make before you exit?
Well, Doc, for me, I guess that I'm completely in a school. I'm listening to everybody's opinions and comments, observations, and experiences. And I must say that I'm just in a learning curve. I'm just learning and listening along. So, as I mentioned earlier, I'd like to thank all of you for the good work you have done. And for those of us who are outside your profession, we would have to do more to support what you do. Looking at the fact that you have issues with stuff that you need for your work and basic motivation that you need for work and the challenges that you go through to ensure that preterm kids are, put in a better place so they become better people in society. So for me, I've just been an observer, a fly on the wall, just listening and watching people who know better than I do. So I'd just like to appreciate and acknowledge all of you again. And I pray that we'll meet on Thursday in Kumasi and we'll take it up from there. So I thank you for honoring me to be part of this discussion. That's about what I can say.
Thank you. Thank you. Thank you so much. Monica, let me come to you. We've been waiting to hear this for a long time. Monica, what are some of the critical psychosocial needs of parents of preterms? We've focused a lot on the preterm, but the parents, what are some of their psychosocial needs? Monica.
I think Monica may have dropped off the phone again. May have a case again.
Okay, so let me come back to Esquire then. Let's talk about money again. So how are you able to sort out health insurance issues? Because when you're charging little monies here and there, health insurance, BNI, everybody will land on you and there'll be a lot of issues. So how are you able to sort out those issues? That's one. Then number two, there are certain fees that we charge on top of the health insurance, the top-ups. When it comes to oxygen, sometimes a preterm baby will be discharged and his oxygen bill alone, what God gives to us freely, his oxygen bill alone will be 3,000 or 4,000 Ghana cedis. How do we really make sure that all these things are provided to these preterm babies without collapsing the finances, without bankrupting the family of this vulnerable baby? Esquire.
Thank you. Thank you very much. So the law is that anyone who is subscribed to National Health Insurance is supposed to receive all that you have signed up as a service provider with your NHIS scheme. You're supposed to provide that to the person without taking any money. And so anything that you take for any service package that is within the conditions of the subscriber, they see them as illegal. This is how the NHIS team treat us as service providers. So if you call it top-ups, here we say coping mechanism. If you call it whatever name you call it, it's seen in the face of the NHIS as illegal. So what do? Over the years, we have taken very cooperative measures, cooperative measures. We've also taken radical measures as well. On 2 occasions, we have had to suspend service delivery to NHIS to draw attention to what was overlooked, but a very serious national canker. I remember in 2014, when we had tried every bit to draw attention to NHIA that reimbursement was at such levels and intervals as to make healthcare delivery simply impossible. We, for nearly a week or even 2, suspended service delivery to all NHIA card bearers. What was the effect? Adult clinics, there was no reduction. Pediatric clinic, there was significant reduction. Obviously, the baby can't speak for himself or herself. It's an adult that has to bring the child. For the adult clinic, like the HPT and diabetic, it looks like since we are in charge of our own decision-making and we definitely don't want to die, we will attend the clinic. So we had a thorough review of the data and what it was speaking to. And we said, next time we'll do it differently. So that led us into the cooperation. The cooperation is to get at the municipal level, the team to appreciate what is it that you're going through. It's not as if you will get them to thumbprint your coping mechanism or your top up or whatever, but to get them to at least appreciate what is going on and what could be better. That's what I first talked about, transparency of intent and the deliverables. Generally, all of us, doesn't matter where you work or whatever your interest is, when we appreciate what the intent is and the expected deliverable, which tells all the stakeholders that it's not like anyone is asking to be given a comfort zone treatment, but we are seeking to do and achieve the same things that you're looking for, you tend to have a cooperation that gives you a tacit or subtle consent to whatever that is going on. Because the key thing is they fear the community reaction. When the community comes out in the public to complain about what is going on by way of the coping mechanisms that we put in place, then they have to respond. They have to be seen to be reacting to that and be protecting the community's interests. But when you bring the community and NHIA around the same desk and you make known exactly what it is that you are seeking to roll out, how it will help, how it will achieve all of us our common goal. Even if they don't give you a written check that says, please go ahead and do it, there seems to be a general cooperation in that regard. That is how, I mean, it's not been smooth, it's not been easy, but that's how over the years we have navigated around this particular dilemma. And yes, we've also seen 1,001 visits by NHIA. We've seen 1,001 visits by, there was one time even the one municipal chief executive actually led the whole press to my office to ask if indeed there were some coping mechanisms that were ongoing, which requires some members of the community to pay something. And then he said, I was in your office because I want to confirm. And we say, well, in my office, I don't see patients. But if you were to go to the clinic and ask what they are paying for and how that is helping, then maybe you can get better answers. But there's nothing to hide. We've had visits from BNI the same way. So everybody is generally concerned. I think the biggest concern is extortion. But if we can put across the challenge and the deliverables expected by the new measures, however you call it, largely you will get some form of cooperation. And this is not a blank check that you can do so across all the clinics, no. But in many ways, in some of the areas that they can appreciate it. This has been our approach over the years. The second part is what I mentioned earlier, that as far as you can get as many of your clients, especially for pediatric on NHIA, then there is a mean, I mean, it affords you generally, because honestly, the pediatric tariffs or NICU tariffs are not that They don't match the cost of service delivery, but they are not that ridiculously low. And so if you can get as many as 95% of the pediatric cases all on NHIA, it's a good start for you as an institution. So your number one safest mechanism is to ensure everybody that is coming through you that is likely to end up in the pediatric ward, whether it's in NICU or in the main pediatric ward, let's have them registered on NHIA. It saves us, it provides us some safety net to then identify isolated situations like at specific equipment and say, this equipment does this magic. See the need for us to take something that we can sustain it. What is the alternative? The alternative is to go through another means of care, which probably doesn't give the same results as this particular equipment. And that was a case that we went through with the Firefly equipment. Thank you.
Thank you. Thank you so much for that very insightful submission and for giving us ideas as to what we can do to help these preterm babies, to help these very vulnerable ones. We'll be opening the lines for questions in a bit, but before we do, but there's just something on my mind, and I just wanted to ask you. I have a feeling that certain families face a lot more barriers when it comes to participating in their baby's care than other families. If it's the family of a baby, a wealthy family, they are more likely to be allowed to participate in their baby's care than a poor person or a poorer family. Correct me if I'm wrong, but what families face the greatest barriers in participating in their baby's care?
Okay, thank you. So, just like you said, we have different families. Let's example, a family of a teenage mother. You know, as parents, we always want our teenagers to go to school, finish school, come home with a big certificate here and there, but at times it doesn't go that way. So if a family of a teenage mother or a teenager give birth to a preterm, there's problems here and there. Parents feeling disappointed in their teenager, not going to school, getting pregnant. The teenager too feeling a bit, there's this guilt, there's this feeling of I've disappointed my family here and there. So there's sometimes there's this conflict between the teenager, the parent, the family, the community, and then there's the preterm baby here we need to talk about. Example, a mother, so now the grandmother maybe financially might not be too sound. Now you are my daughter. I'm taking care of you and your other siblings. You get pregnant, you give birth. Now I'm torn between coming to take care of this granddaughter of mine, take care of your siblings in the house. Some fathers, then they just flare totally. So we have examples like this. We also have examples like a mother giving birth to a family of a mother that's giving birth to multiple babies, like twins, triplets. Some they need helping hand. Okay. Already financially, maybe they might be a little bit incapacitated or help in the house already. She has some in the house. Now she has 2 or 3 to take care of. And then she might need a helping hand. It's not like mother giving birth to one baby. There's the big support system in the house. There's an auntie coming in here. There's a grandmother coming to support here. There is a father, somebody taking care of the other babies in the house. So she has a sound mind to take care of the preterm baby in the hospital. When they meet these challenges of who to help, then there's a big problem. We can also have a family of the mother passing on. Okay, this mother gave birth to the baby and then dies. Already there is that pain of losing the mother. Then there is a preterm to take care of. If it's coupled with the fact that there is also financial constraints, that is a bad show already. The parents and the family of this deceased mother, they come to ask permission to go bury their dead, and then they will come back later to come and take care of such baby. Or a critically ill mother has a preterm baby, and then there is other babies in the house. There are family members too that needs to be taking care of the critically ill mother and the preterm baby as well. So these are some of the families of such people that have barriers, different from those that I must say financially sound, have the support system so they can come in, mother can have enough time to rest and come and take care of the preterm, have people taking care of those in the house, so she's not too much worried. She would be worried because the baby is in the hospital. But when you should compare the kind of worry to the others that have financial constraints, that is a teenager that needs to maybe go back to school to go write her exams and come back. You see, there are some differences here and there. So with these, you see, it's case by case. So when you see we get these families, you have to sit with them, know their problems, and then meet them with their problems. As health professionals, if you need to call the social welfare people, we call them. If you need to call a psychologist to deal with them. But at the end of the day, we'll all be on one page and the baby will be the center. So that if we solve their problems, at the end of the day, we'll be able to take care of this preterm baby. Thank you.
Thank you so much, Sarah. Thank you so much for your submission. Now, let me open the, let me give us the opportunity. If you have any question, you can kindly drop it in the chat box, or you can raise your hand and then we give you the opportunity to ask. If you have any question or any comments. And let me just announce that Thursday and Friday, we will be having our maiden prematurity conference, and it is going to be amazing, the kind of skills that you are going to learn. So if you haven't been able to register, kindly make sure you register. If your administrator doesn't want to sponsor you, please tell him to call Esquire Chris so that he convinces your administrator to allow you to register. So please, if you have any question, you can just drop it in the chat or raise your hand as you are even preparing to attend our Maiden Prematurity Summit. So I'm just reading out what is in the chat. Daniel is saying, respectfully, can't we all be honest and deal with this issue once and for all to avoid the unnecessary harassment from these same agencies? I guess he's referring to the health insurance issue and the coping mechanisms. Now we don't call it top-up, we call it coping mechanisms. We've all learned something today. Can't we avoid this unnecessary harassment from these same agencies who know the truth and in most cases are the first to even suggest top-ups when they are in need, yet they will come harassing you when somebody or a big man reports to them? Ernest is saying the social service support is what we are mostly lacking. Social service support is lacking. Sometimes it's more than people coming around. Sometimes it's the funds that we need for the family. When it comes to the comments, we have somebody saying the thermometer in different languages is making her smile. She's so excited. Emma is saying in closing the gaps, there's the need to train more nurses as neonatal nurse specialists, as well as pediatric nurses with the expertise and skill to be able to, and experience can help reduce mortality of our preterms. Priscilla says the same for pharmacists in various child health services. Investment in human resource all round will achieve desired outcomes. Mr. Kwame Sefakai, Ernest is just excited that you're on the mic here with us. Okay, and My boss said she's going to kill me because I said she's using a concoction. Meanwhile, she stopped using a concoction many, many years ago. All right. Any question, any comments? Okay, if no question, no comments, I want to hear Dr. Pokia's opinion on one thing. What would you say, and as your concluding remarks, would be a low-cost, high-impact intervention for preterm babies that we as a country should prioritize for public funding? Dr. Eno.
All right, thank you, Adoma. Thank you, Adoma.
intervention.
I hope you can hear me.
Yes, please.
Okay, so like low cost, high impact innovations or interventions that will help us, especially those of us in Sub-Saharan Africa, or as we are called with Southeast Asia, low and middle income countries. So one of them, we are not going to reinvent the wheel. Data has shown us that one of the low cost, high impact intervention will be kangaroo mother care. So kangaroo mother care, we all know what it is. It's not only skin to skin, but we know that it's skin to skin, kangaroo nutrition, which is we want breastfeeding, and then kangaroo support, the staff of the unit supporting the mother to the kangaroo and to tell her the reason why we are doing it. And then, of course, early discharge, and then frequent reviews from the house. Okay. So it's been shown that just doing kangaroo mother care, and if you want to get the best benefits of kangaroo mother care, is immediate kangaroo mother care. You know, Prof. Newton, Prof. Anson, Prof. Jikwa et al., they did a study, a WHO study, multi-site, 2019 for 2 years, and then it came out that overall, kangaroo mother care and reduces neonatal death by 25%. It reduces neonatal death by sepsis 36%. And then it reduces the child actually getting sepsis by 18%. I mean, honestly, you would have to do all the kangaroo package. Okay, I know that we are not here to talk about kangaroo mother care because that's a whole teaching or whole training skill set on its own, but it's one of the things that you can do. And then we cannot talk about low cost, high impact and not talk about early initiation of breastfeeding, which is within the first 1 hour of life. At least attempt it. We know that breast milk, I mean, it saves newborns and especially preterm babies. You know that preterm babies with all their problems, formula milk, one of the risks that they're going to get is necrotizing enterocolitis and all the other problems that they have. And even in advanced country, NEC has a mortality of 35 to 50%. So in Ghana, what do you think the mortality for necrotizing enterocolitis is? I don't even want to talk about it. Okay, so early initiation of breastfeeding, we cannot go out and talk about low cost, high impact intervention without not talking about breastfeeding. And then family-centered care. Family-centered, we have been talking about family-centered care in all the things that Adoma has been asking Baba. What do we need? We know that families are part of the health team when it comes to caring for preterms. So there is respect and dignity on our part. Generally, I mean, I've been in the health system for quite some time. At least 20 years I've been working as a doctor and then a pediatrician and then now as a neonatologist as a subspecialty. We have this, what I realized working in Ghana and working in abroad where I trained is that abroad, there's more like parental involvement. And here in Ghana, that's where I work. And we have a very paternalistic attitude towards our mothers, paternalistic as in we know what is best for the child more than the parents. No, that cannot be. Yes, in certain aspects, you may know, but it has been shown that family-centered care, which include respect and dignity for the culture, and then respecting the parents that the baby is for. Obviously, you cannot care more for a baby you have not carried for 9 months or cannot carry it for 7 months than the one who has carried the baby for 7 months, 8 months. That person cares more about the baby than you do. You only think that you do care more than them, but it's not the case. Okay, respect and then partnership with the parents so that they are involved. Let them also be part of the care. It reduces stress in the mothers especially, and even the fathers. And if when those people are not there, the grandparents, the auntie, I mean, when a preterm baby is born, already they are all stressed. The whole family is stressed, okay? And it has been shown that putting them in partnership, involving them with information sharing. We are not hiding anything. If you work under Prof. Planju, you know that honesty is one of the things Prof. Planju preaches. For those of us who worked under her, I mean, if something goes wrong, we tell the parents. If something goes right, we tell the parent. We tell the parent everything, okay? We just add empathy to it, okay? And then let the parents be part of the plan. What can they do? Obviously, they can't set IV access, but of course, they can do the skin to skin in the kangaroo mother care, and that reduces the anxiety in the mother or even the father. I mean, I know that from experience, the fathers, once you put the child skin to skin one day for cultural reasons, the following day, they will not be coming, or they'll be saying, I'm going to work, they'll just come 3 minutes and everything, but some of them also do. But the mothers, the blood pressures that are raised because of her anxiety of her 7-month-old child, baby that she has given birth, she has no idea what is going on. Let her do skin to skin with the child, okay? And then we are saying we are advocating for immediate skin to skin. So just, yes, stabilize the child, but do not wait till the child is off all respiratory devices and everything before you start it, okay? Read the paper about immediate kangaroo mother care by WHO. You see that it even facilitates the child becoming better, the preterm becoming much better, or the low birth weight child becoming much better. Kangaroo mother care is like a drug, okay? It's a drug that helps. It promotes weight gain. And as I said, the parents are part of it. They help with the feeding. We can teach them, those of us who work with newborns, we know that, yes, we can teach the mothers how to do cup feeding. We can teach them how to do tube feeding, isn't it? And then, of course, when we come to respiratory support, we cannot go away and talk about low CPAP. And you see, of course, there are Draeger CPAPs and everything coming from Europe and everything. They're expensive. But now we have values. I mean, I know that not everybody has a lot of values or even have values, but majority have values now than they did previously in 3 to 5 years. Okay, so we have values, and these are things that say are life-saving. Okay, they are more life-saving than just ordinary oxygen. When we are talking about preterm infants and we want to give them a bit of pressure, positive airway pressure, so that the alveoli does not collapse. And then, of course, we are talking about things like caffeine citrate. Caffeine citrate is a wonderful essential drug for a preterm child. We know that it's used as prophylaxis for apnea of prematurity. Initially, we were just doing oral caffeine citrate, and then, babies that are nil per hour, you wouldn't be able to give it because they are nil per hour. But now we have IV caffeine citrate. So these 4 things, and then family-centered care, as I said, these are things that we can incorporate, and then it will make the survival of preterm infants much better, because we have seen that something like, I always go back to kangaroo mother care. It's not the only thing, but I've talked about a lot of the things there. It's one. It also makes preterm stay shorter, okay? The preterm stay shorter, reduces stress in them that will affect their neurodevelopmental outcomes, which are already sometimes lower by being born extreme preterm with like extreme low birth weight. But all those stressful hormones come down, it gives them a better outcome than those with a stress hormone. So I just want to say that all these things, we can't forget I know Dr. Rekubrobe just walked away from me just a couple of minutes ago. I cannot forget about hand hygiene, because I mean, it's something that he's passionate about. We cannot talk about preterm care of a preterm or a neonate and not talk about infection prevention practices. These are just washing your hands before you touch the child and after the child, before a procedure and after the procedure, and teaching the mother to do so and all stop doing so are a few of the things that we can do and to help the preterm baby that we are all passionate about saving to survive and to fulfill their God-given potential. Thank you very much.
Okay, thank you so much. So right now I'm going to waive my duty as the moderator to give the closing remarks, and instead I'm going to ask my panelists to give a one-sentence closing remark. So Sarah Baba Bruce Smith, could you kindly give us your one-sentence closing remark? Equitable care for every preterm baby.
Okay, thank you. So what I would say is giving birth to a preterm is a bit challenging. But with the help of the family, health workers, the community, and the society at large, we can help make this preterm care a better one. Health professionals do their bit, family members do their bit, organization, the government, each and every member plays its bit. When we all come together, it becomes one huge goal. And then with that, care of the preterm baby will be a very good one. And then the outcome will be what we all want to achieve. Thank you.
Thank you so much, Sarah. Fam Ann, one sentence.
Okay, what I would say is that preterms are very unique in terms of medication administration. Normal protocols, really, because of their weight and their size, they need a lot of adjustment. So integrating your pharmacist will help you with medication reconstitution, dilution, and tailoring it to the specific neonates that you cannot draw your medication go a long way in improving outcome, even guiding you on how to administer it based on how tiny the baby is crucial. So involvement of pharmacists and standardizing our protocol is key to ensuring the survival of preterm babies. Thank you.
Thank you so much, Fam Ann. I wish I had time to go into what you just said, but let's move on. Dr. Prince Odami, one sentence.
Thank you very much. I thank the Holy Family Hospital so far what they've been doing with the students at KNUST and with the research lab opening up their unit for us to come and see what is going on and also conduct research with us. I would encourage all the facilities, especially Confanoche, to also do same to help us come up with more innovations that can be used to save the lives of these preterms and helping their treatment.
Thank you so much, Dr. Prince Odami. Now, Esquire, your closing remark, one sentence. This is like your closing argument, right? One sentence.
Thank you, Dr. Adma. It's a remark. First, thank you for the opportunity to be part of this. The key thing is to increase advocacy on the economic or cost burden of taking care of preterm babies or generally newborns in our hospitals. I think many stakeholders underestimate this. We may take it for granted that even within the space of the healthcare delivery system, everybody appreciates what it takes. If you appreciate the initial remarks of Dr. Pokua in terms of all the things that are required, high-skilled labor, sophisticated equipment, advanced medications, then you will appreciate the burden immediately placed on families, and where that fails, transfer to the institutions, because nobody at any level of the healthcare delivery system will see a baby die when they have the medication, the equipment, or whatever it takes to save that baby. It never happens. So first, it falls on the family, and when they fail, it's transferred to the institution. And where the institution is unable to find funding mechanisms to meet this gap, then it gets to a point where the institution is incapable of taking care of the future because of inability to replenish. So advocacy on the funding needs for newborn babies is what I would say. And I know pediatricians do very well at this advocacy within the institutions across health policy levels. Thank you very much for the opportunity to be part.
Thank you all so much. Let me hand over to Dr. Josephine Oduro-Chinebwa, and she is the chairperson of the Prematurity Month Awareness Local Organization Committee 2025, Local Organizing Committee 2025. Dr. Jyoti, can you do the official launch of the conference? And after that, Dr. Emmanuel Opon, the Vice President of Pediatric Society, will stand.
Hello. Hello, good evening. Okay.
Yes, Joe, go ahead. We can hear you. I think we lost Adoma. Go ahead.
Okay. So good evening, everyone. I'm so glad to have all of us here. As she introduced, I'm Dr. Josephine Oduro-Chinebwa, a pediatrician with Confanoche. And I'm honored to be called upon to be the LOC chair for this year's Prematurity Conference. Special mention to our special guest of honor, Mr. Kwame Sefakai. Thank you so much for staying through. And let me correct this, he'll be launching the conference for us. I'm just here to tell us about the conference and what to expect. And thank you all so much for being here. You are champions of our most vulnerable citizens, which are the preterm babies. And a wonderful panel discussion we've had today. Thank you so much to all the panelists. And we know, we've been hearing the statistics all through the month, since the month started, that every day we are having babies born too soon. Some arrive in the tertiary institutions that are fully equipped. They have full teams that take care of these babies. Many others arrive in the small district facilities where it may just be one nurse caring for several mothers and babies all at once, where equipment is limited and survival often depends on just a few timely life-saving interventions, which this nurse may not know about. And yet, even in the face of all these challenges, there's one truth that stares us in the face, that every preterm baby in Ghana deserves an equal chance at life, irrespective of where they are born. And this is the heart of our theme this year. This year, we are looking at equitable care for every preterm baby. Now, this vast gap that we've realized between the well-equipped facilities and then the under-equipped facilities is what has carved this theme out for us. And the conference we're about to have in a few days is our response to this inequity. So this year, year in, year out, we've always had the Prematurity Awareness Month, where we dress in purple, we light up everything in purple, purple balloons, we make noise on radio, on TV, just to create awareness so people are aware that there's a group of vulnerable citizens called preterms that have challenges. But this year, we decided to do something about it. And that has made this conference very necessary. So what are we seeing? This year, we are calling out to the frontline health workers, where we are all going to meet up. We are going to learn more about preterms. We're going to equip each other with skills and knowledge so that we go back to our facilities well-equipped and ready to save more lives. And we realize that when systems and skills are aligned, survival improves dramatically. Okay. So this conference is actually a movement. It's not just the usual academic ritual where we meet and learn about things. This time we want to make a difference in the care of preterms. So I'm so excited to be in the forefront with my other LOC members to bring to you our very first prematurity training conference being organized by the Pediatric Society of Ghana. In addition, for the first time, we're going to have a tech and innovation fair. Okay, it was very refreshing hearing from Dr. Odami. And a few weeks ago, I happened to be in a meeting where I saw these young, brilliant engineers, coming up with very innovative ideas and equipment just to help in neonatal care. Okay, and it's very unfortunate how sometimes they're stuck away in their labs trying to come up with solutions, and we are in the clinics facing the challenges, and we hardly ever meet each other. This year, we want to put a stop to that. So we are going to have a tech and innovation fair where for the first time we'll showcase something that's truly special. So across Ghana, we're going to have brilliant engineers, clinicians, innovators that are building things locally. I was very impressed 2 months ago when I went to a hospital and I found out that an engineer, locally situated engineer, had built an incubator with a phototherapy for his unit. And the cost was so affordable. He built it, he knew how to service it, he knew how to repair it if there were any challenges. So I believe that we can be innovative for ourselves, create things for ourselves, repair them, and we are responsible for everything we do for ourselves. Excellence doesn't always have to be imported. Okay. And what do we expect in this conference? It's a 2-day conference. So day one, we're going to have lectures, and then we'll have a scientific session. So the lectures will be delivered by seasoned neonatologists from all over the country. And then for the scientific session, we are just trying to encourage us. As you are working in your bid to improve care, gather data, look at what the data looks like. And then when you see the gaps, you can intervene. So we are calling on everyone to bring your data, tell us what is going on, tell us your stories that are going on in your NICUs. And then on day 2, that is when we do the hands-on training. Okay, we're going to have different stations where we're going to learn a lot about CPAP and all the things you've mentioned, kangaroo mother care, how to do it and how to do it right. You're going to have instructors that will teach you how to do kangaroo care, how to even set up CPAP from materials you can find in your NICU. You don't have to wait for an institution to donate CPAP to you. You can build your own minimal CPAP in your small corner. Okay, that will make a huge difference in preterm care. And then we're also hoping that you will network. Okay, it would be very nice for a nurse in a district who feels so alone managing these preterms. She comes for a conference and then she meets one neonatologist, a senior nurse from a tertiary institution, who she thinks knows so much. We share contacts, and then whenever she's in trouble, help is just a call away. Okay, so we are hoping that this conference will afford us all of these opportunities. So our goal is simple, that every participant will return to their facility empowered, confident, and equipped to save more lives. So please, if you haven't made up your mind, if you haven't registered, we've projected the flyer. The flyers are all on our platforms. Please register, okay, and come for this conference. Come and learn a thing or two and contribute to improvement in our neonatal outcomes. And we are gathering because the data is clear. Neonatal prematurity deaths is still the leading cause of neonatal deaths in Ghana. That is a stark reality we are stuck with. So we are here to make a difference with that. So thank you so much. So as LOC Chair, I'm honored to walk this path with you. And I invite our respected chairperson to officially launch this maiden National Prematurity Conference. So thank you for being here.
Okay, thank you so much, Dr. Jo T, our Honorable LOC Chair. Our moderator has had internet challenges and she has stepped out. I am Dr. Emmanuel Opon, Vice President, Pediatric Society of Ghana, and I'm standing in place of my president, Dr. Hilda Boy, who is not able to join us, to declare that this Prematurity conference is here to stay, and we are all going to go purple together. We are going to stand till every preterm baby in Ghana gets the care that they deserve. And I want to invite our LOC chair again so that we can declare together the official launch of the National Prematurity Conference. So Dr. Jyoti, I want you to come back, and together we declare the official launch of the National Prematurity Conference, which is here to stay till every preterm gets the equitable care that they deserve in Ghana. Is Dr. Jyoti back?
Yes, I'm back.
All right. So we are declaring, so we declare our maiden National Prematurity Conference duly launched. Go Purple, go
we are going
PSG,
purple. Go PSG, go purple.
go preterm warriors.
Yeah, thank you so much.
Yeah. So wherever you are, you can clap, you can shout purple, you can wave your purple flag, wave your purple dress, because come Thursday and Friday, we are all going to KNUST Impact Building to have training sessions, network together, interact with our innovators, and make sure that every baby everywhere, preterm baby everywhere, gets the equitable care that we are all advocating for this evening. So with these few words, thank you, and over for now. We will invite Dr. Mame Frema Kotomoti, our Secretary, PSG Ashanti, to give us a few announcements. Thank you, and over. Okay, can I be heard?
Clearly. Yes,
Okay.
clearly.
All right. It seems our secretary is not able to give the announcements, but let me take the opportunity to mention again that we want every district in Ghana to send a representative, 1 or 2 or 3 people from the various neonatal care units, to be trained and equipped and empowered to be able to provide the minimum care package that a preterm baby will need, and we didn't have to travel several kilometers to access this basic care that has been discussed during this panel discussion. So we are encouraging our facility managers, our leaders, our nurses, our doctors, our physician assistants, our midwives to advance this agenda, push your facilities, push your stakeholders to ensure that you make it to this training. There is still room for a few more. And even if you are a late bird, you still pay the same price as the early bird. That's the good news. The other good news is that the LOC is exploring an option for those who, for very good reasons, are not able to make it. We are still going to discuss and see how best we can accommodate you. But the training is very practical, it's very intensive, and it's very, very dynamic. So we are encouraging the in-person participation. Otherwise, you miss out on the practical skills that you really need to go back to your facilities and make the difference for these tiny heroes. So this is the main announcement. All the others, stick to your WhatsApp platforms. We'll be sharing all the updates, and we can't wait to meet all of us. Thank you, and over, and bye-bye for now. Aye. So you have to eat a lot of kokonte to be ready for Thursday and Friday. Okay, so prepare and come and let's all go purple. Go purple wherever you are.
Yeah. You. That's why I say it's 9 years now. I'm already in September.